reason it's failed is there's an underlying mechanical problem in the knee. There can be many different types of mechanical problems, but you have to address the mechanical problem and at the same time try and encourage cartilage to grow. And we've got a big program of work trying to understand the abnormal mechanics to try and actually prevent the arthritis.
There's a gentleman there.
If I could just ask, you mentioned that doing half knees now, there's a system, a very small insertion you can make and put in the relevant stuff, and you can do it both sides. So why do you need to have a complete knee? Why can't you just do two halves and make a one?
Yeah, there are, just to make it confusing, there are three bits of the knee. I'm not sure I've got one here. Can't get into the boxes. No. Anyway, you'll have to. The third bit is the kneecap. We haven't talked about that, but you can also get arthritis under the kneecap, and so we can replace this bit of bone at the front with a metal shell and a bit of plastic that goes under the kneecap. So actually, we've got three half knees. Which doesn't quite work. But it is actually possible to put in two half knees at the same time, and we've done about 10. It's interesting, when John Goodfellow started 30 years ago, he didn't believe in just putting one in. He put 300 of inside and out one side ones in. They didn't work very well, actually, which is why we now use the single one. But you can also put in one on the inside and one in the kneecap. We've done quite a lot where we put one on the inside and replace ruptured ligaments. And we haven't ever done three, but other people have. And I've seen one X-ray from France where a French surgeon had done all three halves of the knee, three uni-compartment replacement, and he replaced the ligaments. But I did tell you at the beginning that it is actually more difficult to get a half knee in than a total knee. And it's certainly more difficult to do two half knees than a total. And actually, as we've heard at the back, total knees do work, as I said at the beginning, do work incredibly well. So actually, our general view is if there's bad disease throughout the knee, it's much better to do a total knee. It's very reliable. But we can. Yours is a great point. We can put it together in pieces. And perhaps the most useful thing is there are an awful lot now of patients who have one half in, and very occasionally the other bit of the knee wears out, and then we can replace that as well. That does bring up one other point. There's been a general perception that if you do one half of the knee, the other half will inevitably fail, because the perception is there's something wrong with the cartilage. But actually, that doesn't seem to happen. And at 20 years, after doing one half of the knee, it's only 1 or 2% of the other side that's worn out, which suggests, going back to the earlier question here, that the underlying problem isn't a problem with the cartilage, otherwise it would fail. The underlying problem is a mechanical problem. And that's why we're so interested in trying to understand the mechanics.
And in fact, just to emphasise that point, if you look at all of the published work on cartilage disease, a half knee replacement, rather ironically, is the only intervention that's ever been shown to stop the progression of arthritis. So if you put it in early enough into someone who has one half of the knee damaged, they won't get damage on the other side of the knee, the vast majority of them. And that's something that I think David and I are constantly astonished by, that you can arrest this process with the joint replacements, not only get rid of the pain, but stop the progression of the disease.
Yes, with the rising life expectancy and the fact that age 70 may be young in a few years' time, as it were, how do you anticipate that this will go and everything will wear? Or are going to be lots of 100-year-olds with worn-out knees but still active?
Yeah, I mean, I think Andrew showed you the graph of the primary knee replacement. It's going up by many factors of 10.
And all the obesity.
Yeah, well, that's from the United States, where they have a big problem with obesity. But it's going to be a huge demographic problem, certainly the primary knee replacements. With that, and with people living longer, we have to do many more revisions. And they are a completely different league.
I think we need to get the Primary Care Trust in to have a demonstration.
Yeah. But this is the kind of thing we have to put in for a revision. Huge. This is a revision step. We're putting in huge bits of metal. This is a revision of a knee replacement if it goes wrong. We have to put in huge bits of metal. We really want to avoid them. But your point is well made. With the population living longer and being more sporty, so getting knee replacements earlier, we're going to have a huge problem with these revisions.
I think that something that demonstrates that is, I think as a knee surgeon, you used to think of treating someone's arthritis as something that you did when they were 70, and you did a total joint replacement. But now, we're very conscious that you can intervene at a much earlier stage, which might affect what happens as play to age. And so it's really a treatment pathway that the patient is on from an early age through to an older age. And I think that's how we'll have to manage that problem, because it is going to be a huge burden.
And what should we all be doing to keep our knees healthy?
I would say, exercise is great for the knee, and if you do exercise, then you're stopping overweight. And those two things, don't run marathons on tarmac, but other than that, exercise is the key. Exercise is wonderful. It's good for your heart, but it's also good for your knee, and it's good for your hips. It's great. And more than that, you can't do. Unfortunately, again, as Andrew alluded to, it's your parents' fault, probably, if you get up.
Can you replace the resurfacing metal on metal if it has gone on and caused abnormal tissue?
Yeah, we can always replace a joint replacement with a bigger one and a bigger one and a bigger one. We end up replacing the whole treatment. With these resurfacings, the most common problem, actually, perhaps not surprisingly, is the bone breaks across here. And that's a common problem. Well, it's not common. We consider it common, but it's about between 1% and 2%. And then we would just put in a standard, take out the resurfacing, and put in a hip replacement with a big head. So that's.
But I was thinking of the abnormal tissue.
Yeah, I know you were. I was going to get onto that. The almost always problems with wear, debris, and loosening causes loss of bone. We're very good at reconstructing bone with big bits of bone, but we're not good at reconstructing the soft tissue. And if you get all this debris, it can damage the soft tissue and the muscles. And we're really not good at reconstructing muscles. Plastic surgeons can move muscle flaps, but they don't work really well. Well, they don't tend to work when you move them. So we're not good at reconstructing the damage to the soft tissue caused by the metal debris. And that worries us, and that's why we stopped doing it. But again, we perceive it as a big problem. But in our whole, we've done 1,500 resurfacings. It's 1.8%. So it's, it isn't.
I'm just one of them.
Yeah. Well, I don't know how. Obviously, yours isn't that bad, but it's a thing that worries us, and we have had a few bad ones. We do our best to reconstruct them with the plastic surgeons, but they at the moment they're not brilliant. How is yours? We probably should talk about it after.
Yes, there'll be a chance. Yes.